Hello, good morning, good evening, everyone, and welcome to our debate webinar of our series. I extend a welcome to everyone joining us from a corner of the globe. It's an absolute pleasure to have all of you us live on webinar of Zoom. Today, we are delighted to welcome a distinguished guided solution expert who will deliver a lecture on the treatment planning to diverse clinical scenarios, the key of success. Allow me to introduce our esteemed guest, Dr. Khaled Hussein. Dr. Khaled Hussein, he has a bachelor degree and Master of Science of Oral Surgery, Cairo University, and he is a PhD in the Dental College of Georgia, USA. He is a consultant of oral surgery and implantology in the National Research Center in Cairo, Egypt. And he is the head of dental department, implant and oral surgery specialist, KIC Joya Clinics in Abha, Saudi Arabia. And he is an OSSTEM OIC faculty member. It's a great honor to welcome Dr. Khaled tonight. Welcome, Dr. Khaled, to our webinar.
Thank you so much, Dr. Stephen, for the nice presentation. And,
You're welcome. Thank you very much for joining us today.
I hope the sound is okay with everyone.
It's clear.
Okay, let us start. So today's lecture title is the treatment planning for different clinical scenarios, which personally I consider the key of success. My name is Khaled Hussein, and I consider myself an oral surgeon and implantologist. So we are here today to continue learning, so we can stretch our flat circles into upward spirals. I know that attending and preparing such a lecture for you guys does this for me, and I hope I do the same for you. And unfortunately, the fight is still going about implantology. Is it a surgeon specialty, a periodontist specialty, a prosthodontist specialty, and people who are working in the shadow like radiologists and lab? Is it who is considered an implantologist? Actually, to be honest with you, it's a team effort, and only with this team effort you can have happy patient and successful results. So in order to outline implant planning, we need to have an introduction about different aspects and the prerequisites for implant treatment, and we need to define the guidelines for single implant cases, and then multiple implants in cases of partial edentulous and implant-supported bridges, and then immediate implants. We won't be able to, we don't have enough time to cover this section. It's very important. There is a high demand from patients, mainly on immediate implants, and it shows very successful results. And the bread and butter of implant dentistry, which is full arch rehab. Fortunately, it will be presented by an eminent and capable prosthodontist, Dr. Amr Khadim. And finally, the implants in the aesthetic zone, which was also be presented by an eminent and capable periodontist, Dr. Abdelazim Hazem. So we will have a simple introduction, and we will discuss the guidelines of single implant cases and multiple implant cases. So the first advice to myself and to all of you is to seek help before you need it. And this is actually a case where if you did this case, you definitely need help. And this is a summary of the need of such lecture, because we see here everything and only one cause of all these problems, lack of planning. Okay, and I'm sorry to say that most probably whoever planned this case is a surgeon So he was only concerned about osseointegration, and a lot of mistakes were done, and mainly lack of planning. Another case where we can see horrible failures, fractured screws, 3 out of 10 implants with fractured screws, 1 on the verge of being fractured, lack of planning, the long span, connecting natural teeth to implants, lot of bone, crystal bone resorption, almost all implants, up to the half the length of the implant. So this for me is a waste of time, waste of money, waste of effort, and definitely a waste of reputation. So are you ready to shape the world, or let the world shape you, or be shaped by the world? Okay, and to start with this historic picture, and one person who actually shaped our profession is Dr. Manama, who introduced the concept of osseointegration and kind of invented the branch of implantology in our profession. However, since this picture was taken, the implantology, science evolved a lot since that time, and we can actually define implantology now by as the prosthetic rehabilitation using dental implants, which actually requires accurate implant placement to have predictable, functional, aesthetic, and long-term successful outcomes. This is the actual definition of implant dentistry. And here we have to differentiate between 2 terms, a successful implant and a surviving implant. And the team in 2007, where osseointegration at that time was the main concern, they actually defined criteria of success into just absence of pain or tenderness, 0 mobility, less than 2 millimeters radiographic bone loss, and no exudate history. However, our success criteria now are much more than only these factors. And even in 2025, if you have a look at such a case, it is complete and utter failure, even by the 2007 standards. So when we talk about implant dentistry, freehand implant placement, what your essential needs are: combine CT that generates DICOM files that you can upload into a viewer software to perform your implant planning. And personally, nowadays, I consider this planning for osseointegration, not for full accurate implant placement for predictable, functional, aesthetic, long-term successful outcome. So if you only do this, success will be doubtful. So you have to increase your practice by a notch. So not only DICOM files, but add to them scanning of the oral topography, generating STL files, and then merging the 2 together in what is called as computer-assisted imaging. And then you start with your prosthetic planning, and then implant planning according to the your prosthetic plan. And this is called computer-assisted design. I believe that in order to reach successful long-term implant rehab, you have to at least do these 4 steps, and you can increase it by a notch and invest in yourself and your patient and your profession, and make your guide and have a guided surgical kit and to be able to perform fully guided implant placement. So, unfortunately, OSSTEM provides a very nice tool, which is the One Guide Kit, and it's user-friendly, and it allows you to make sleeveless, keyless guides all what you need to do is plan and have a 3D printer, and you're good to go. And it's available for all implant diameters, except for the 3.0, which has a separate kit, which is called the MS Guide Kit. Anyway, our topic today is not about guided implants only, but just to let you know that it allows the clinician, guided implant surgery allows the clinician to think ahead and place the implants in a position and depth and angulation, considering the future prosthesis, which personally I consider the key of success. So please try a low or no pilot program. Give it a try to get your idea of off the ground. When we talk about implant planning, it's really overwhelming. A lot of patient-related factors, systemic condition, local conditions, habits, parafunctional habits, a lot of factors. And when we talk about implant planning, the implant design, implant type, distribution, experience. So there are overwhelming details, and we need not to lose sight of the big picture. And ironically, the big picture in implant planning is simply single implant cases. If you know how to place single implant properly and perfectly, this I consider the key of success or to success. So in implant planning for single implant cases, it's head to toe or top to bottom planning. You have to plan your prosthesis first, and then you place your implant accordingly, because having an edentulous space, you plan your prosthetic type, shape, and material. Before then, you choose your abutment according to the prosthesis design, and then finally you place your implant accordingly. And this could be considered an accurate implant placement, which can provide you with predictable, functional, aesthetic, long-term successful outcomes, and ultimately will lead you to success. So in order to place a single implant to restore an edentulous space, we have to consider three very important views: the occlusal view, the buccal view, and the sagittal view. Concerning the buccal view, if we have a missing tooth, we have to consider the central fossa curve, lingo-occlusal curve, and the bucco-occlusal curve. And when I place my restoration, it has to coincide with these curves in order to be a successful restoration. And here, in the occlusal view, we have three main zones. Okay, the danger zone, which is from the buccal aspect. Remember, I have to stress on that all my talk today will be concerning posterior teeth, because the numbers are different in anterior teeth. So in the danger zone is 1.5 millimeters buccally, 1 millimeter lingually, and 1.5 millimeter proximally. Okay, the yellow zone is the position that where cantilever grows. And yes, in a single implant, you can have the cantilever effect. You don't have to have two crowns to have cantilever. No, you can have cantilever in a single implant. And the aim of our ideal prosthesis production possible is to aim in the blue zone. I need to place my implant here, which coincides almost in the central fossa of the future prosthesis. So to put these numbers into action, if I need to put a 4.0 millimeter implant, I need at least 6.5 millimeter width of alveolar ridge. 4.5 millimeter implant, I need at least 7 millimeters ridge width. And to be honest with you, these are the two main diameters that I use. I usually reserve the 5.0 millimeter implant as an emergency implant in case the 4.5 or even the 4 do not show good primary stability. And the 6 millimeter implant is, I use it as an ultra short implant, which is a viable, useful option that you should try to use. So why do we need 1.5 millimeter buccal bone? Why? Because less than this, and here one of the very important lessons is we have to respect biology. Okay, if we have a buccal plate less posterior, less than 1.5 millimeter thick, resorption will happen, and severe crestal bone resorption will happen. It might end up by you losing the whole buccal plate, and this actually violates your biological width dramatically and leads to exposure of the implant threads, which leads ultimately to complete failure of the implant. So when we consider the buccal view when placing a single implant, the placement site is very important to so not to generate cantilever forces. So the site, if it's too much mesial or distal, it's going to be in the yellow zone. It will generate cantilever. If it goes into the red zone, mesiodistally, then it will compromise the implant to tooth distance, which might endanger normal tooth. And definitely, if it's less than 1.5 millimeter, it will lead to inter-implant dental bone resorption. The placement depth of the implant is another very crucial factor, because the implant depth actually secures your biological width. And since if you are using a cone connection implant like the OSSTEM TS implant, you need to be 1 millimeter infrabony and at least have 2 millimeter of soft tissue above, and this gives you the least of 3 millimeter biological width. Personally, I prefer to make it 4 millimeter biological width, and this by making the gingiva thicker than even it's 2 millimeter. There are ways to make it thicker than this. And also the placement depth is very important for the natural emergence profile of your prosthesis. So, and natural emergence profile is important even in posterior teeth. And also it dictates the depth of the implants, dictates the prosthesis type, material. Okay, if you have enough length because of governed by the depth of the implant, you can go for cemented crowns, and if they're not, you have to go for screw retained restorations. So personally, I prefer in all cases a screw retained restoration, and I'll tell you why later. But another factor that is specifically important for single implant cases and dictated by the placement depth of the implant is the crown to implant ratio. Very important factor in single crowns. And finally, the placement angle. If you have a tilt in your implant, mesially, distally, buccally, especially mesially and distally, okay, you will definitely have a problem in the insertion axis of the prosthesis. So let's put these information into action into this case. we have here, and this highlights also the importance of how to read economy MCT, how to make your measurements, how to identify your anatomical landmarks, like here, we see here the inferior alveolar nerve, inferior alveolar foramen. So we have here a ridge of 4.99, 4.9 width, almost 5 millimeter width. So I have two options here. I have two options. An easy option, which is option number 2, is to just place your implant in the available bone width, okay? And it will also integrate, and then solve your problems later, if you can see these problems. But the other option is to choose an implant diameter that is compatible with the future prosthesis. So this is option 1. Place your, the easy option, place your implant in the available bone. Okay, you ended up, but it will also integrate, and it will be very strong. You will have no problem in osseointegration. But now, implants are not about osseointegration. When you fabricate your prosthesis, you will have what we call a ridge lap crown, So this is extremely annoying for the patient. Food impaction here, you will definitely have resorption inflammation in your crestal bone, and the increase in the oblique forces will also add to the crestal bone resorption. So option 2, or the right way. First, we have to design our prosthesis, design our crown, and choose the implant diameter that is compatible with this crown, and have it at the depth that is compatible with a good biological width. And here we have a high risk of buccal thread exposure. So we need to add any technique to expand our ridge, so we can place our implant without thread exposure and with 1 millimeter, 1.5 millimeter of buccal bone, of protective buccal bone. So we can do this by many ways. One of them is guided bone regeneration. And we will, if we do it the long, hard, costly way, we will end up by having a normal, functioning, long-term, successful restoration. This is another way to view it. Here we see a ridge lap prosthesis. It's really annoying for the patients, believe me. I've seen it a lot. It's easier to make and with less costs, but you will end up by losing the whole implant and prosthesis. And this is the hard way, which is the better way to do it. So top to down treatment, plan your prosthesis first. As we mentioned, a very critical factor in single implant cases is the crown to implant ratio. As a general rule, the apical 3 to 5 millimeters of any implant are mainly essential for primary stability. However, when the implant is put into action, they start functioning by attaching prosthesis to it. All the load and all the stresses are concentrated in the crestal 3 millimeters of it. So a finite element study we done back in 2013 shows that the increase in the crown implant ratio from 1.1 to 1.25 to 1 actually increases the stresses in the crestal part of the implant by 35%. And when you make your crown to implant ratio 1.5 to 1, it actually increases to almost 85%. And this is destructive. You will have a lot of problems you will have loose screws, you will have chestal bone resorption. You might end up by having even fractured, loose or fractured implant. So the crown root ratio dictated by the implant depth is a very important factor, especially in single implant cases. If we go back to the occlusal view and see this yellow zone, which is the cantilever area. Okay, another study, and it shows here the same thing, that the stresses are concentrated in the apical part, in the crestal part, on the crestal 3 millimeters, top 3 millimeters of the implant once it's put in action. So if you apply an oblique load of 250 newtons just 4 millimeters away, and then compare it to 6 millimeters away from the center of the implant, you have a 34% increase in stresses at that point, just 2 millimeter wide. So ridge lap crowns are actual cantilevers, whether it is too much mesial or too distal. Okay, here you have, this is a huge amount of stresses on this part that will lead eventually to crestal bone resorption here in this area. And you might have a problem, if you're lucky, simple problems like screw loosening, and it might unfortunately end up by fracturing the implant or the screw. So definitely we need to feel more. So this underlines the importance of positioning the mesiodistal position of an implant. And a ridge lap prosthesis also, ridge lap crown can also be created in if the implant is too much lingual, or the implant diameter is not appropriate for the crown. So if you apply load here, it will definitely make crestal bone resorption locally, in addition to the inflammation that will be caused by the food infection in this area. So please try to avoid ridge lap crowns as much as you can. And this is only done with proper planning. You have to do planning either for single implant cases. Another very important factor is the mesiodistal width of the tooth to be restored. And usually we face this problem with the first molar. Sometimes the mesiodistal width is too high, is too big for a single implant. And that's when we have to make the patient invest in his treatment and substitute the single implant by 2 implants. And this will actually decrease, have much influence on the bending forces that are applied to single implant. But by the end of the day, patients will have long-term successful restoration of single tooth. So these small beginnings actually lead to big achievements. So if we adopt these factors applied to simple or single implant cases, we have to take them over to multiple implant cases. And we start by having 2 posterior missing teeth. We have a big dilemma and a big question whether to make them singles, to restore them as single implants, or to restore them as splinted implants. All the literature shows that splinted implants are much better, but there are some advantages of the single restoration of implants, of not splinting them. It's easier to make. If you have a problem in planning, it's easier. If you have a problem in your prosthesis, it's easier to fix. But you still have to perfect the contact in these splinted implants. However, when you splint your implants, you have no problem in contact between the 2 implants. The load is distributed and over the 2 implants. However, you have to plan these implants, because any discrepancy in the angulation might have a problem in fitting. And we will discuss this later today. If you have 3 missing implants, the more, the better. but unfortunately, it's a financial in these economic situations. It's usually not the case. But if you place 3 missing teeth with 3 implants, you make them as singles or you splint them. Definitely splinting is better. However, it's harder to make. It has to be planned properly. Okay, so the ideal solution, not the ideal, but the more economic solution is to make your bridge. And if you make a bridge, then they should be splinted. So the better results come with planning, proper planning, implant position, implant angulation, direction, depth. All this has to be planned. If we have 4 posterior teeth missing, okay, the more the better. But if economy allows, we'll splint them in 2 segments, okay, and making a single bridge, or you splint the 3 implants together, making the 4 units bridge. It's fine. Making having the 2 anterior abutments, 2 anterior implants and 1 posterior implant, or having 2 posterior implants and 1 anterior implant, it's okay. And having the bridge and a single implant, yeah, much easier, but still the bridge is splinted prosthesis, so it has to be planned properly. So what are the considerations for splinting? And this opens up a very important aspect. Do we cement or screw our restorations? Personally, I prefer, and I think the literature supports this, that screw-retained prostheses are much better. You have, for the long-term success, you have no possibility of residual cement. You will not be violating your biological width, biological gingival seal, which is very, 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 very important for the long-term successful prosthetic rehabilitation using dental implants. So if in a case like this, you have properly aligned implants, 2 options are available. You can make them as singles, but you will find it hard to adjust your contents. If you splint them, it's much better, and better load distribution on all the osseo-integrated implants, and you have no problem in the contact except with the natural tooth, and it's not a problem, you just to adjust it. But there is a very important factor when you splint, which is the passive fit of your prosthesis. The passive fit is essential and mandatory. And the passive fit is essential in a single abutment, in a single implant, and mandatory and very important in multiple implants. And it's crucial when we're dealing with full arch cases. So passive fit, what is passive? Passive fit means simply that I need to insert my prosthesis fully seated without the use of screws. So how do I know that? I need to screw. When I screw, they only tighten for a quarter turn. If the screw is used to force the implant in place, to force the abutment in place, this is not passive fit. This is actually huge stresses. Even if you succeed by the end at the fitting your prosthesis, this is huge stresses on the screw, on the crestal bone, and on the implant itself. So a very useful option that we have to use. It's easier to use, and it makes life much easier when you're splinting your implants or you're doing a bridge, which is available also in the OSSTEM system. The non-hex abutment, they are or the in other systems, it's called the non-engaging abutment. Use it in all splinted cases and all your bridges. You have to use it. It makes your life much easier. So the passive fit, if it's that crucial, you have to have passive fit checkpoints. So the first checkpoint is actually planning. You have to plan, and you have to do a top-down planning. That's why I told you that the big picture is the single implant placement. Planning, planning, planning. Plan your processes and place your implant accordingly. And then when you take your impression, you have to do, I recommend that you do verification jig, okay? Adding steps in our profession, adding steps always leads to better results. Omitting steps always leads to bad results. Most probably will lead to bad results. So the verification jig is a very important step. And we're talking about the passive fit. So passive fit could have it. We can lose our passive fit due to two problems. One is the angulation discrepancy in the angulation of the implant. Two is soft tissue interference. So how can I be sure my verification jig on the fabricated in the lab on the cast away from the gingiva excludes the gingival factor in the passive fit. So if you have your jig on the cast and it fits exactly in the patient's mouth, then your angulation is okay. And if you face any problems in the fitting, most probably it will be during delivery of your prosthesis or during try-in, because try-in is very important. This is most probably a soft tissue problem that you can adjust easily, hopefully. And by the end, if you have a passive fit, you'll be able to place your implant, splinted implants or bridge passively, and it will stay there with no loosening, no screw loosening problems, no screw fracture problems, no induced stresses at the distal part of your ridge for a long time. So, if you have improper planning or execution of your plan, and you have a discrepancy in the angulation of splinted implants, whether they are splinted, whether it is a bridge, you actually lose your passive fit. You can never regain it with regular screw-retained restorations. So you can solve this problem by compromising. Usually, personally, I hate to compromise. I hate it. And compromise in this case would be use cemented restoration, angled abutment and cemented restoration, or make a reduction in use cemented restoration, and go through the risks and of violating your biological seal, violating your biological seal and biological seal. So you can regain your passive fit, but you have to invest. You have to know your tools. You have to explore the available tools. And one way of regaining this is by using different types of abutment, like the convertible abutment with the convertible angle cylinder. Okay, you can apply it to one or two of these implants in one case, and it's actually very forgiving. Or use multi-unit abutments, as you will see in some of our cases where we intentionally do angulation of our implants. So these are tools that you can adopt and you can use. So keep your options open. Invest. Yes, they are more costly than regular implants. However, they can help you to regain your passive fit, to be able to install a screw retained restoration. It's not guaranteed, but you should keep your options open, and especially when there is a discrepancy in the angulation between splinted implants. Another very important concept that I usually adopt is the short-term dental arch concept. Okay, the second molar is very hard to restore, and personally, I don't go for restoration of the second molar unless some factors are available, like enough interocclusal space, wide mouth opening, uh, presence of full set of teeth, full set of teeth. It's really hard, and you can place your implant. Yes, you can place your implant, but it's going to be extremely difficult to put your prosthesis, screw in your prosthesis, your abutment. It's really tedious. So, and at the same time, the functional stability. When only pair of posterior tooth is present, only one posterior tooth is present, functional stability is easier because the first molar is actually the key for occlusion. So these are some cases that I need to show you. These mostly are screw retained prostheses. I don't think I did cement the crown maybe 6 years ago. All my cases are screw retained. And here we see proper planning, bridge, splinted posterior bridge. And this is the picture 4 years after insertion of the prosthesis. Another case, multi implants. Use your tools, use the available tools, okay, and explore the available tools. 65-year-old female. She's a relative of mine, so I wouldn't go into extensive procedures like sinus lift. All of you definitely know recommendoma syndrome. So proper planning, proper implant placement. And actually, prosthesis, and unfortunately, I don't have a picture of the prosthesis installed. However, definitely, if there is a problem, I would have known of, because, as I said, she's a relative of mine. Everything was perfect, and planning is the key for success. Another case where we adopt the single implant into the multiple implants. So this is how we do it now. Planning of our implants, digital planning of our implants. Whether you do a surgical guide or not, planning is very important. And as we see here, all the axes of the implants are within the central fossa of the future crowns. So this is actually an 85 years old lady. So guided surgery, flapless implant placement was actually very good for her, very important for her. And this is how our plan is. And this is a short video showing the steps of planning. And I would like to highlight here that Dr. Omar Khaled, he is the one who's doing the planning for me. And none of this work would have been done without his support and collaboration. Amazing guy, considering my friend and colleague. So here, first step is to merge your combined CT files to the STL file, is the intraoral scan file. Merge them together. Further details will be about the planning for guided surgery will be available on the guided lecture. Here, everything is clear. Bone, soft tissue. This is my biological width. This is my biological width. Another very important factor in planning, anatomical landmarks. See here. I didn't go into much details in this for the sake of time, but the inferior alveolar nerve, the mental nerve, mental foramen, very science, of course. So tracing inferior alveolar bilaterally, that's what is being done now. And choosing your implements. Okay, this is the key. Okay, so place your prosthesis first. You adjust it, size, shape, emergence profile, everything. Positioning the arch, and then you adjust your implant accordingly. Okay. You see here this yellow line. This is the implant itself, and this green line is 2 millimeter safety margin. So if we see here, we have 2 millimeters buccally, we have 2 millimeters lingually of bone, and we have more than 2 millimeters of safety between the implant and the natural tooth, neighboring natural tooth. And we have our implant within our target area, which is the central implant axis within the central fossa of the future crown. Final adjustments, and in place, and you do the same for the 4 implants, marking your the boundaries of the surgical guide, making the holes to ensure seating of the surgical guide, and then reviewing everything before looking the guide, putting the name of the patient, and then executing your plan. Another case, 4 missing posterior teeth, 3 implants, 2 anteriors, 1 posterior. Planning for the canine. Distance between natural teeth, buccal, bone, lingual bones, everything is in place. Then, first premolar, same. Planning. First molar, planning. This is a 72 years old female. The surgery was done flapless. Another tool we can use. We mentioned the multi-unit problems. Okay. In this case, it doesn't show here exactly the sinus, but in order to place an upright implant here, we need to do sinus lift, and this is a 72 years old woman. So, and personally, if I try to make things cheaper without compromising the quality of the work. So, and taking in consideration the age, the systemic condition, the ability of the patient to withstand lengthy procedures. So I went for guide, design, inclined implant. You see here, okay, the first premolar implant, planning, and the first molar. We put it in an inclined way, and we adjust this inclination using 30 millimeter, 30 degrees multi-unit abutment. So by the end, we should have a screw-retained fixed pieces without the need to do sinus lift. I'm not saying don't do sinus lifts, guys. I mean, you have to have patient selection. Okay, very old patient, and you know from dealing with this patient that he cannot stand, he cannot understand the concept of sinus slip. So try to find a way around it without compromising the end results. Actually, I'm sorry, this should have been post-operative picture of this. It's like I missed it. I'm really sorry about that. But it turned out beautifully. Actually, in this case specifically, when I placed my implant, especially the distal one, I thought I was placing it in the sinus, but it turned out to be perfect because of the primary stability. And I can tell you 4 months from now, if we meet or if we get to another webinar, I can tell you if I believe in OSSTEM or not, because it's really challenging to have osseointegration in such soft bone. Another case, 72 years old male, planning for single implant, top to bottom planning. Another case where we have planning and we have a sinus problem. And this also is performed nicely and without any complication. And let's go back to this case. This patient is a 72 years old female, and usually I'm not I do not show off in front of my patients, although it's showing off is part of the profession nowadays. But specifically in this case, I told her daughter, she was escorting her. Okay, once I put a surgical guide in place after anesthesia kicked in, I told her, okay, turn on your stopwatch. We put 3 implants. And when she turned up the stopwatch, we had the whole procedure finished flapless in 8 minutes, which is great. And to tell you one thing, I work by myself, almost by myself. I get assistance or any instruction. So very, 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 very important and efficient tool to upgrade to the guided surgery. So to conclude this talk, I would like to mention that planning, even for single implants. I don't remember the last time I had a patient into my clinic and I opened his mouth, gave him anesthesia, and just put an implant. I don't remember this. You have to plan your case. Invest in yourself, invest in your patient, invest in your armamentarium. You have to go beyond the stock abutments, okay? You have to use tools and seek help. Seek help before you need it. I seek help from other professions, from other specialties. I seek help from younger guys. I seek help from anyone that I consider, because you can be master of one, but you can never be master of all. And as we agreed from the beginning that it's a teamwork. An implantologist cannot excel in all aspects of implantology. So you need to seek help. And respect yourself, respect your patient, respect your profession, and definitely respect biology. Respect the biology of socket healing. Respect the biology of bone. Respect the biology of soft tissue. Respect the biology of your gingival seal, and respect the biology of your gingival attachments. And before I end, I would like to extend my sincere thanks to Dr. Omar Khaled, amazing collaborator. in the implant planning and surgical guide fabrication to the OSSTEM Middle East team, specifically Dr. Stephen Ahmed. Great help always from this guy. And I'd like to extend my thanks to the mastermind of this webinar series, Dr. David Chong, and the other mastermind of this webinar series, Dr. Marco Alcaideli. And extend my thanks to all of you, guys, and thank you for this.
Okay, thank you very much, Dr. Khaled, for this insightful lecture. I believe a lot of us have gained a lot of valuable knowledge in this presentation. Thank you very much for your acknowledgement.
Thank you.
Okay, so
If anyone has any questions, please.
yeah, we
go
have
ahead.
got. Okay, so we can write down in the Q&A section. So until now we have like one comment and two questions. So one comment is from Dr. Markandi. He is asking to explain about the implant in the anterior region.
Well, the implants in the anterior region will be covered in a separate lecture by Dr. Abdelazim Hazim. To be honest with you, if you want to hear the fundamentals and basics of the implants in the anterior region, it has to be, in my opinion, it has to be a periodontologist. So we have an eminent periodontologist which will be covering this part. In implant planning, as I said, you cannot cover everything. I try to focus on important parts and set the foundation for other more complicated cases to be explained by other colleagues.
Yes, sure. So maybe you can save the date. It will be June 6th. We will have another webinar. You will find our all social media, but the registration link soon to attend for the comprehensive aesthetic implant placement. Okay, we have another question from Dr. Riyadh. In your second case for the two short implants near the sinus, so when can you determine to do sinus lifting or using short implant?
Well, it's an economic decision and a patient-related decision and a skills decision. So some patients actually refuse the concept of having an added surgery. So you try to provide them with another variable option. And to be honest with you, in order to use short implants, you have to have a really wide range, because the ultra short implants, they range from the diameter of 5 to 6 implants. So you need to have at least 8 millimeter diameter or at least 9 millimeter diameter. I'm sorry, 9 millimeter wide range. So it's a multifactorial decision. But what I wanted to highlight here that you can still work around problems, okay? If you know your tools, if you know the available tools, and train yourself how to use them. Placing ultra short implants is not easy. It's not easy, and they have to be. You can incline your regular implants, and they will also integrate, but you cannot incline an ultra short implant. So they have their own rules, and it's a nice tool to use if you know how to use it. They are very useful in the mandible also. Instead of doing unless you're not compromising your crown root ratio. So what I mean here is if you have a very high inferior alveolar nerve and onlay bone graft is not viable, so you need to do let's say lateralization of your inferior alveolar nerve to put an implant. An ultra short implant would be much easier solution than going through other procedures, extending the time of treatment, extending the cost of treatment. So that's my answer.
So how about the success rate of these short implants? Not just only about osseointegration, but after loading the prosthesis.
I haven't seen any problem. As I told you, okay, when we load the finite element analysis, actually this is the analysis that opened the window for ultra short implants, because we know now once the implant is osseointegrated, all the load is in the crestal 3 millimeters. So if you put your implant and you achieve good primary stability of an ultra short implant, and then you load your prosthesis passively, it will survive because the load is in only the crestal 3 millimeters. So it doesn't matter if it's short or long. Actually, to be honest with you, in the beginning of my practice, I used to always use very long implants because I mean, you treated them like they were screws in the wall. Okay, and then actually long implants they make it difficult to direct, more difficult than shorter implants. So now the maximum length I use is 10 millimeter implants. I use longer than this only in immediate implant cases where you need longer implant to engage in the subsocket bone to get primary stability. This is the only time I use long implants. In a healed socket or in healed bone, 10 millimeter implants is quite sufficient for me. 8 millimeters, no problem. Okay, it's all about the diameter, the planning, and the stresses that you put the implant in, which are concentrated in the crestal 3 millimeters. So ultra short implants, they are very, very, very useful and good tool. But placing these implants, it's like you're placing a bullet. So it's really, really very technique sensitive when you're placing it.
Thank you for your answer. We have another question. How can you determine the success of osseointegration during healing period?
Okay. A very important indicator is the primary stability. Okay. And the primary stability, I have a very simple test of detecting it. When you screw in after you place your implant, definitely you feel you have a torque meter. So if you are within the range between 20 to 35 newtons where you're inserting your implant, you're very good. You have very good primary stability. Okay, and another test is when you screw in, simply when you screw in your cover screw. Okay, in some cases where I feel that the primary stability is compromised, I mean less than 20, I don't put a cover screw because your fingers can actually apply like up to 25 newtons, with your finger tips. So if I am concerned about the primary stability, I don't screw in my cover screw because I don't want to push the implant deeper. Okay. Usually with the OSSTEM implants, I even between 10 and 20 insertion torque, I didn't have any problems in primary stability. I mean in osseointegration. And osseointegration relies mainly on your surgical procedure. The torque that you use during drilling, the speed that you use, the copious irrigation. If you stick to the basics of osseointegration, you will have no problem if you stick to the basics of surgical part of the implants, you will have no problem. And usually you test this primary stability. There are a lot of ways to test it. And test osseointegration usually with X-ray, okay, periapical X-ray, CT. And you have to be aware that of the beam hardening effect. That's why radiology is very important. Because sometimes you see a black line around your implant, even though they are properly osseointegrated. So don't worry about it. If it's a regular thin line, this is the beam hardening effect of the X-ray, reflection of the X-ray on the from the titanium. And the actual test is when you uncover your implant, screw in your healing abutment, okay, or try even to unscrew the everything will be okay. And this means that everything is okay. And when you screw in your healing abutment, you do like a simple test like the dull sound test. There are machines and instruments and ways. This is for me the simple way. And then you screw and unscrew your healing abutment, everything is perfect, then you have perfect osseointegration. And you only can be sure of this if you have proper planning.
Okay, thank you for your answers. Maybe I can add also that ISQ, maybe some clinics can have it
of course.
also.
Yeah.
Maybe. Okay, so also we're having a question how to make impression for screw retain the crown. I think it's a little bit a big question.
It's the same impression. It's the same impression. Okay. And you can do it analog and digital. Okay, you take your impressions with a scanner or with analog lab analog and your lab analog and impression coping, regular impression. And so I understand the question now. So it's not, what we do is actually not technically screw retained. We do extraorally cemented, the correct term, extraorally cemented, intraorally screwed. So you do your lab work as usual, okay, and then they design the crown with a hole, occlusal hole in the along the axis of the implant, and this is an option that is available in Exocad. And then after everything is finished, the crown is cemented in the lab with special types of cement that are very hard to if you want to break the bond of this cement, you have to put it in the furnace, I think at 900 for 3 minutes, 900 degrees for 3 minutes in order to break the seal. This is much more powerful than our cement. And at the same time, they have the freedom to remove any excess cement. And a very important thing, this is a very important lab trick, is that zirconia is a very nice biocompatible material. Porcelain is a really nice biocompatible material. However, in order to get benefit of this biocompatibility, you need to any zirconia that is subgingival, you need to not glaze it, unglaze it, make it hand finished only, no glazing or no staining of any zirconia subgingival. This will actually induce and promote the gingival vital attachment. And this improves your gingival seal. And this is very important for the long-term survival of your implant and success of your implant. So that's why personally I prefer and I like to design my implants and my implant prosthesis as screw retained. And when I face an obstacle, I always try to find ways around it to keep it screw retained. Because I personally consider that cemented crowns on implants are a huge compromise.
Thank you. We have a lot of questions, so I will try to pick up only few that we can answer quickly. What is the maximum crown implant ratio we can do?
In single implants, it's different than in multiple implants or full arch implants. But in single implants, don't go beyond 1.25 to 1. This means that you have a problem either in the implant depth, okay, or in the implant planning itself. You need it to have only bone graft, for instance, for example. So if you plan properly, you'll never be stuck with this problem. 1-to-1 is perfect. 1.25 to 1 is okay. Beyond this, for single implants, again, I have to stress, for single implants, posterior. So this is the way it should be, I think, as I know.
What is the narrowest size implant that would be used in the posterior region?
This is a very, very, very good question. And when I was preparing this lecture, there was this chart that all the implant companies have of the different sizes at different positions. But we actually don't need it, because if we plan your crown dimension, your prosthesis dimensions actually dictates the diameter. So you don't need that. But as a general rule, posteriorly in single implants, I use 4.5. I can use 3.5 in splinted implants. And usually this is for premolars, if they have narrow mesiodistal width. So the answer to this question is simply top-down planning.
Yeah, this is the clear answer. Okay, we have a second. Maybe it will be our last question, unfortunately, because we don't have a lot of time. So what do you do when you don't have passive fit of the prosthesis? Do you do soft tissue?
Okay, the passive fit is crucial. This is something you have no way around it. If you don't have passive fit, don't continue. You have to solve the problem. Either go for cemented and compromise your restoration. This is the easy way, or try to solve it. Okay. Passive fit could be compromised by two things. First, the big problem is the improper alignment of the implants. Okay. First of all, in splinted implants and bridges, please, it will make your life much easier. Please use non-engaging, non-hex abutments. Most of the systems, they have it. OSSTEM, they have it, okay? And if you work with a system that doesn't have it, have your lab reduce the hex in the abutment, so it becomes non-engaging. This is number one. Number two, do verification jig. The verification jig, you are connecting your implants, rigidly connecting your implants on the cast. If the problem is severe discrepancy in the angulation, okay, and your jig does not have any contact with the soft tissue, if there is a huge discrepancy, actually, when you make the jig and try to remove it from the cast, it won't come out. It won't come out. It has no path of insertion. It won't come out. And even if they forcefully take it out and you try to place it inside the patient mouth, it will never fit. Okay. And if it fits, it will break. because the verification jig is done with duralay, which is very rigid. If you try to bend it, it will break. So this means here that the problem, the absence of the passive fit is due to the angulations of the implants. Okay. Here we have to think about switching to cement retained restoration or trying to adopt any other way around it. Like we mentioned, the multi-unit abutments, angulated multi-unit abutments. Here you have to have a stand and analyze the problem. Which implant is causing the problem? Which is angulated? What is the angle of that needs to be restored? And check on the cast first, the multi-unit abutments or the or your convertiment abutments. Okay, use your tools. If the fit and then place your abutment in patient's mouth, because you switch one or two of your impressions into tissue level impression instead of implant level impression when you put when you take impression of the using the regular lab, the regular impression coping. This is called tissue implant level impression. When you have your implant, when you have a multi-unit abutment or a convertiment abutment, this is called tissue level impression. So you put your abutment in place, take the impression, leave it, and then you have different analogs and different setup for this. If you don't have a fitting problem with the jig, which is away from the soft tissue, okay, and you try in, okay, again, more steps, better, easier problem solved. Okay, so verification jig, try in, and the try in better to be cemented also. I mean screwed in, okay, with the resin cement, so it doesn't fall apart when you try to insert it. So if you have your jig okay, and you do your try in, and you have problem in fitting, most probably you will feel springing action in the fitting, springing action. So this is a soft tissue problem. So check the interferences with the soft tissue, remove it, try to seat, remove it, try to seat passively. It will be much easier with the try-in, the PMMA try-in, than if it's zircon, and until you reach your passive, your complete passive fit. And passive fit means complete seating of your restoration, okay? And when you screw your screws, okay, you have to screw them like you screw your tire, okay? Not one screw all the way and then the other screws. No, make them until it starts tightening. You feel it started tightening, until you feel it started tightening, and then tightening should only be for a quarter turn. And this principle is very, 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 very important in full arch rehab, and definitely Dr. Amr Khadim will be addressing this point. Okay, what if I force my prosthesis, screw retained prosthesis in? Okay, force it with the screw. Okay, a lot of stresses will be induced on the screw. A lot of stresses will be induced on the crestal part of the implant. And if you recall the picture, the failed implants, full arches implant, you have three broken screws out of 10 implants, and one on this restoration was forced in. It was not passively fitting. It's a huge problem, crestal bone resorption, and it could lead to, with the addition of some parafunctional habits, minor parafunctional habits, it will easily lead to implant fracture. And it's not the implant problem. So I hope this kind of detailed the passive fit issue.
Thank you for the tips. Thank you for these tips. So I want to ask about this passive fit. If we have the tissue, like preventing the passive fit, can we open the flap and then or just remove it?
Look, this is an effort between you and your lab. Okay, if the emergence profile of your prosthesis is perfect, then you might, and you have proper papilla formed, everything is proper, you can, but bear in mind that any area exposed of zircon exposed to soft tissue should be unglazed, unstained, and only hand finished. This will expose the virginity of the zircon so that the gingival fibers will attach to it, and this will make the gingival seal perfect. In the anterior region, it's quite different because you actually shape your tissues, your papillae first, and then you construct your crown according to the shaped one. So this will be definitely covered by in a more detailed way by Dr. Abdelazim in his lecture.
Okay.
I think I'm gonna treat myself with a very nice expensive meal, and it's gonna be your treat.
So, sure. Here in Dubai.
No, you come here. It's a better one.
Yes, I agree. Okay, so we really thank you so much for this nice Q&A session. And I believe we all learned a lot. So we are coming to the end of our webinar. So I would just like to make some announcement. So our coming webinar will be on the 25th of April. In this month, our esteemed lecturer will be Dr. Hatem Rajdan from Jordan. He will present a lecture about the posterior maxilla and evaluation and treatment options. Okay, this will be in Dubai time, 6 p.m. So it's end of this month, coming very soon. And the next event we are having, it will be a hands-on seminar with Professor Kyung-Won Kim from South Korea. It will be 27th of April. So it will be just 2 days after the webinar. It will be in the OSSTEM Training Center in Dubai. And the seminar topic will be achieve predictable and accurate implant placement with digital workflow using one guide and one case. And yes, it will be interesting one. And next is the last announcement for now will be another hands-on seminar with Dr. Wasim Al-Malhal from Lebanon. It will be on the 9th of May at OSSTEM Training Center in Dubai. The seminar topic will be guided surgery and new vision in internal sinus lifting. So both of the seminars actually they are exclusively for the UAE doctors, for United Arab Emirates residents. So if you want to join these events, please reach to our sales guys in the UAE or reach to our Instagram page for the registration. So I think we came to the end of our nice webinar, very nice, insightful lecture by Dr. Khaled. So I would like to appreciate and thank you very much for your nice lecture and nice Q&A session. And I would like to thank every attendees for joining us today and hope to see you next time.
Thank you so much, and really appreciate your presence, everyone who attended this. Really appreciate it. And thank you so much, OIC Middle East, everyone. A lot of effort, a lot of insight, and a very nice vision for all of us. Thank you.
Thank you very much. Thank you once again for joining us tonight. We look forward to seeing you at the next event. Have a great day. Goodbye. Goodbye.